Good evening and welcome everyone. I am Dr. Komal Lalwani and on behalf of Nationwide Quality of Care Network, I welcome you all to today's Community of Practice. The title of today's Community of Practice session is on Fetal Neurology, Current Landscape and the Path Forward by Dr. Sonika Agarwal. Now moving forward, I would like to call upon Dr. Vikram Datta to introduce our speaker of today's session. Dr. Vikram Datta is the Director Professor of Department of Neonatology, ABVIMS and Dr. RML Hospital, New Delhi. He is the President of Nationwide Quality of Care Network and former Vice President of National Neonatology Forum, India. He is the guest editor of PMJ Open Quality South Asia edition. He is the member of editorial board at International Journal for Quality in Healthcare Communication. He is expert at the International Society for Quality in Healthcare. He is the lead for National Mentoring Group and Technical Resource Group Lead for Sustainable Model for Lakshya by Ministry of Health and Family Welfare, India. He is also the member of QED, that is Quality, Equity and Dignity Working Group by Ministry of Health and Family Welfare, India. Over to you, sir. I request you to please welcome as today's speaker, Dr. Sonika Agarwal.
Thank you so much, Dr. Komal. In fact, it is a wonderful opportunity and a great occasion to welcome Dr. Sonika Agarwal, who not only happens to be a great clinician and great individual par excellence, but also one of my seniors from Banaras Hindu University. Ma'am has been trained as a fetal neonatal neurologist at the Division of Neurology and Pediatrics at Children's Hospital of Philadelphia, University of Pennsylvania. She's a clinical chair at the CHOP Family Steps program, starting early with psychosocial support. She's been the co-founder of the Fetal Neurology Consortium. She's a member of the steering committee of the CoLAB Global Pregnancy Collaborative and a director of the Resident Fellowship Board and associate editor of Journal of Child Neurology and Child Neurology Open. Ma'am has been an ex-faculty at Obstetrics and Gynecology and Maternal Fetal Medicine Department at All India Institute of Medical Sciences, New Delhi, India, before taking upon her appointment in the prestigious CHOP Hospital. So today, ma'am is going to be talking about a very important topic, which is quite, new to most of us. And I think a lot of DM students also would be joining this, besides the quality teams, ma'am. And we would be very eager to listen to the concepts of fetal neurology from none other than your mouth, ma'am. And we look forward to interactive session. Over to you, ma'am. The floor is all yours.
Thank you very much. I will just share my screen. So is this showing full screen?
Yes, ma'am.
And it's advancing?
Yes.
Okay. Okay, thank you, Dr. Datta and the National Quality Network team for giving me this wonderful opportunity to share my work. My career started in India as a high-risk obstetrician and maternal fetal medicine specialist from IMS BHU and then at All India Institute of Medical Sciences in Delhi. And then I trained as a child neurologist in the US after my move and specialized in fetal and neonatal neurology. So while my career took a 180-degree turn from the foot end of the bed to focusing on babies' brains, I throughout every year and with each patient that I see, I understand more and more about how these two fields are so interconnected. And I'll be presenting an overview of fetal neurology, which is a newer field. It's part of the specialty of fetal and neonatal neurology, where we focus on early diagnosis of brain disorders starting from early in pregnancy, and some of the work that we have done to improve quality and education in the field. So I'll be giving an overview of what fetal neurology is, discuss some challenges in the preconceptional prenatal counseling for common fetal brain disorders, And also I'll present some work as we develop the Fetal Neurology Consortium, which is in line with the wonderful QI work that you all have created in various centers. So if you look at the global burden of disease, later in life, it is in the range of 10 to 15% for neurodevelopmental disorders of various types. However, if you focus at the green on this chart, in the neonatal period, which is the 0 to 28 days, the DALYs, or what we call disability adjusted life years, so years spent in disability, the percentage is as high as 40%, primarily due to prematurity and various conditions that lead to what we call now neonatal encephalopathy. So beyond even hypoxic ischemic, various other disorders that could lead to presentation of a newborn with encephalopathy. So what are the concepts behind fetal neurology and the approach to the field of fetal and neonatal neurology? You're all aware of the first 1,000 days. That's the period starting from conception through the first 2 years of life. And this is the critical and sensitive period of brain development where various genomic, molecular networks, tissue networks, and various systemic maturation happens, and that is influenced by the gene interaction, the maternal immune activation, the environment of the fetus, and then the environment of the baby as the brain matures during the period of maximum growth. So fetal neurology focuses on this early period where we can catch fetuses who may be at risk for adverse neurodevelopmental outcomes. Starting with the pregnant mom, there could be medical disorders of pregnancy. There could be obstetric complications such as hypertension, gestational diabetes. There could be autoimmune conditions. There could be other systemic conditions that impact the health of the developing fetus. Exposures such as drugs, alcohol, medications, toxic exposures, and then other toxic stress, and most importantly, mental health and nutritional disorders. So all these can impact the developing brain. Then comes the interaction with the placental conditions. So placental diseases, ischemic conditions, dysmaturity, and early aging of the placenta, as we see in hypertension and diabetes. Then there's fetal growth problems, and then fetal anomalies and genetic disorders. So a large part of fetal neurology focuses on these placental conditions, fetal anomalies, especially brain anomalies, and then how the medical and obstetric complications can impact the fetal brain. It also looks at congenital infections and the impact on the fetal brain. And then there's the perinatal events, which may lead to adverse outcomes. Now, neonatal neurology, the field started out with neonatal neurology, so focusing on how when a baby presents with encephalopathy, whether they had a hypoxic ischemic injury or seizures or stroke or bleeds in the brain, adverse effects from prematurity, or other genetic and systemic conditions which could lead to adverse outcomes. But now with fetal neurology, we are learning about the at-risk babies early on in pregnancy. So if you try to understand how fetal neurology approach works, early on in pregnancy, after the anatomy scan, which is done usually around 18 to 20 weeks of pregnancy, sometimes a little earlier, if there's suspicion for anomalies, then they will get an ultrasound at the with the primary first step. And if there's a suspicion, some of these patients will be referred to a higher center with expert neurosonographers. Or fetal MRI started out in the late 80s when the American College of Radiology, through the studies, they said like this is safe in pregnancy and where benefit outweighs the risk. And There was some initial concern about impact on the hearing of the baby, but then trials were done and it was found to be safe. So usually fetal MRI will be done after the ultrasound has suspicion for fetal anomalies. Then genetic counseling and counseling with the maternal fetal medicine or obstetric specialists along with genetics, and then the system that is involved. If there is a CNS anomaly, fetal neurologists will get involved. And we talk about genetic testing options, which could be done through amniocentesis, starting with either a karyotype and chromosomal microarray, or any specific gene panels based on what anomaly you are seeing. And now there's even this role of whole exome sequencing, which is increasingly being used in fetal and especially more in neonatal neurology. Then the early diagnosis and continued monitoring with ultrasound for serial measurements and growth and any progression of any anomaly or conditions that I'll discuss in the next few slides. And then how the pregnancy advances and there's changes in any medical or obstetric complications, which could impact our discussions about the location of the delivery, referral to a higher level of care, timing of delivery, and then comes the role of all the multidisciplinary teams that connect at time of birth and in the perinatal period, sometimes where high risk adverse outcomes are affected, where we think the baby may be at risk for even survival or decision-making around the time of birth, then palliative care teams and neonatology will also get involved in the perinatal period. And after that is the care of how multidisciplinary therapies and early intervention and long-term follow-up and outcomes are followed over time. So prenatal testing will include ultrasound and fetal MRI when indicated. Fetal MRI is a complementary test, which is done after the ultrasound. And then is the role of the genetic testing. Then it helps us with the birthing plan and the perinatal monitoring. Do we need to do ultrasound more frequently? How frequent is the biophysical monitoring? Role of other consultants and involvement around the perinatal period. And then also it helps us well in advance with the counseling for the family and going over what's the diagnosis and what are the likely outcomes, and having a team of specialists connected with the family early on so the birthing plan, the perinatal period, and the postnatal follow-up can all be planned. Now, I'll give an overview of some of the commonly seen conditions in fetal neurology. And this is, if you look to the top image on the right, this is a fetal MRI that was done after a referral with an ultrasound showing dilated ventricles. And so this baby, the fetus had huge expansion. Anything above 15 is considered severe ventriculomegaly. And there was also IVH. There was lining of blood around the ventricles, and then the blood trickling down, causing aqueductal blockage and aqueductal stenosis to the outflow, so blocking the outflow of the CSF. So there was progressive ventriculomegaly. This baby was born and got a shunt, and this is the neonatal scans, the next 4 pictures that you see on the right, and had extensive genetic testing, which was inconclusive, got a shunt in the first month of life, and was enrolled in therapies. And she's doing extremely well. She's started out with some motor delay, and with therapies she caught up, and with the early shunt and early rehabilitative care, her outcome is really excellent, and she's speaking in full sentences and fully conversational and wants to be a neurologist. And but there is always a spectrum. So this is the good outcome that I'm showing, but there may be a patient where this same MRI may be associated with more adverse neurodevelopmental outcomes. So it's the complex interaction, the area of the injury, and what the environment and therapies and parental support can do to change the outcome. This is another example of a twin pregnancy where fetal MRI was done. You see, this is the dilated ventricle, and this is the tightening of the aqueduct. This is, again, the fetal MRI, and then the neonatal MRI in the middle here, showing some flow. So this baby was actually followed and didn't require surgery, has developmental delays, but walked around almost 2 years of age, and is now enrolled in speech therapy, but is walking very well and is already speaking in phrases at age 2 years and did not require a shunt. So with any brain condition, there's always a spectrum of outcomes that you can expect, and that poses the challenge to counseling for these families. So we do share what we know, and then the unknown of what exactly will only be clear as we learn to follow these kids and see them mature over time. Now, this is another fetal MRI of a lady who was referred to us quite late in pregnancy for milder ventriculomegaly. So this was around 12 to 14 millimeters, mild to moderate, and there was some septation in the ventricles. So whenever we see septa, so the initial thought was that was it a choroid plexus cyst versus some septation due to infection. When the baby was born, she had petechiae, and urine CMV was done and was positive, got treated with valganciclovir for 6 months for congenital CMV. The postnatal MRI showed some mild inferior Wormian hypoplasia. You see increased mineralization and some septations in the ventricle. So some mineralization in the white matter, which is seen in CMV. And she was quite severely delayed in her first year. But from second year, she really started gaining skills. She was in with PT, OT, speech, needed vestibular rehab therapy for balance issues because with the Wormian and cerebellar impact from the CMV, she would lose balance with every time she turned or tried to get up or change positions. And she also has hearing loss. She wears hearing aids. But intellectually, she's very preserved. And for a 3-year-old, her skills look quite advanced with cognitive skills. But we are still watching. She's at risk for learning disorders and processing. She's a little hyperactive. So with this white matter changes, you can sometimes get a diagnosis with attention deficit and other neurodevelopmental learning issues. Now, so if you look at ventriculomegaly, whether it is the cause is infection or a bleed in the brain, or whether there's an associated genetic or syndromic condition, that determines the outcome. It's not just the degree of ventriculomegaly. So degree of ventriculomegaly is one thing. The progression is more important. If ventricles continue to increase with follow-up ultrasounds in pregnancy, then we suspect more of an ongoing insult with a genetic or infectious or other etiology. And some of these families have opted for genetic testing prenatally, and syndromic diagnoses have been confirmed. Also, the presence of additional structural anomalies can change the outcome for these diagnoses. Now, looking at some other example for ventriculomegaly due to the IVH, the intraventricular hemorrhage. So IVH, one is the IVH that is related to prematurity, but these are prenatal hemorrhages, which we are catching early in pregnancy because they get referred after the ultrasound. And this is the MRI showing extensive parenchymal destruction on one side. And then initially started out with one side and went to the other. And then this baby had a shunt placement in the first few days of life, 4th day of life. And then genetic testing was done, which was inconclusive. We're seeing increasing diagnosis of collagen mutation. Many of the patients have been diagnosed prenatally. There's again a spectrum with this condition. And this is her follow-up neonatal MRI. And this kid was slightly delayed, but walked at 17 months and has had some staring spells, has not had seizures, but is at very high risk for seizures and still enrolled in therapies. Now, with looking at the challenges of counseling in the prenatal period, now you look at these scans which look both started out with hemorrhages and ventriculomegaly. There's some variation in the degree of ventriculomegaly here. You're seeing the susceptibility image with these dark spots, which is the blood. And this kid walked at 16 months, has speech and language delay, and has a diagnosis of autism spectrum. And with this MRI, which is looking better than this degree of distraction and distension of the ventricles. The kid on the right walked at 16 months, has normal speech, and has had one seizure with fever and had a shunt in the first week of life. So the trajectory of the development and how they progress is more important than what we see with a picture in time. So the long-term outcomes with ventriculomegaly and hydrocephalus, the key to good prognosis, early detection and treatment. Many of these kids may have requirement for shunt revision, shunt failures. The risk of intellectual disability is there in about as high as 35%. However, with rehabilitation, early intervention, special education supports, many of these kids are doing quite well and lead normal lives. Now, this is the spectrum of injury and dilation and of the ventricles. You see the pregnancy MRI here, and with this big bleed and huge expansion on one side and moderate expansion on the other side. This kid was diagnosed prenatally with the collagen 4 mutation and had seizures at birth, required shunt in the first few months of life, and has global developmental delay, also with optic dysatrophy. So collagen mutations can affect the brain, they can affect the kidney, and they can also have cataracts and retinal changes, which can lead to vision problems. Again, looking at the spectrum of the injury and outcomes, so some kids can have more focal injury and leading to a cystic encephalomalacia, what the old term was porencephaly. And then you see multiple scattered bleeds here with these dark spots and around the cerebellum, injury to the cerebellum. This kid was profoundly delayed, had spastic quadriplegic cerebral palsy, and intractable epilepsy, then went for palliative and hospice care, and then passed away in the second year of life. So there's always the spectrum, but with collagen mutations, with extensive hemorrhages and injury, the outcome is usually profound neurodevelopmental delay and seizures. Now, another condition we see is the midline defect. So usually ultrasound will catch diagnose absent septum. And then that leads to looking at the prosencephalon. So how is the front of the brain developing? And most of these pregnant women will get a fetal MRI. Now this one had a missing corpus callosum. You see the connecting fibers on the two sides are missing, and the ventricles have this parallel orientation. Now with corpus callosum, there is always a wide spectrum of anomalies. They can be kids who can be mildly delayed, and they can be kids who can have more severe neurodevelopmental delay. The ones who are mildly delayed can have some motor delay, speech delay. They finally catch up with their skills, but they can have learning disabilities which get diagnosed when they are in their higher grades. They can have a diagnosis of ADHD also. Now, there are patients who have come to us for headaches, and then they get an MRI and they get diagnosed as a teenager. So that's also the other spectrum, when an older child who may not have had the diagnosis confirmed in early period and never had a scan, and the pregnancy ultrasound at 20 weeks did not diagnose it, the diagnosis then came later in life. However, some patients can have more significant neurodevelopmental delay, and those are the ones. Ideally, recommendation is for any brain malformation, a genetic panel such as a brain malformation panel, or increasingly whole exome is being used. For agenesis of corpus callosum, we do recommend testing, and some of the kids who are more delayed or where the ventricles were more enlarged. Or progressive enlargement, they did turn out to have some genetic syndromes which were diagnosed later and with the whole exome testing postnatally. Now, if you look at this colorful picture on the right, so this is a functional DTI image which is being done. And they looked at, it was a smaller cohort, but it's a very important study. They looked at where the connection is there, the corpus callosum versus where the corpus callosum is missing. And in the kids where the corpus callosum was missing, these functional MRIs, they showed that the intrahemispheric connections were strengthened. The structure remained the same, but it was the functional network and connectivity that had changed. And so it's possible this is serving as a model to understand why some of these kids with neurodevelopmental disorders and missing part of a brain are actually doing better than what we think. So because the networks get established differently and new connections, neuroplasticity, role of the environment, all that can impact the outcome. Now, to look at some of the other challenges. So this was again another corpus callosum missing early in pregnancy. This patient had progressive enlargement of ventricles. Now, our limitation in early pregnancy is that the fetal MRI done in early 20 weeks of pregnancy, between 20 to 24 weeks, the brain is still maturing. The layering of the cortex, the folds of the brain, they are not established yet. So we always bring it into the counseling because this patient got an MRI at 21 weeks and there was progressive ventricular dilation, and the postnatal MRI showed a cortical malformation, which was not clear with the earlier MRI. So there's this limitation has always to be brought in. And this kid was actually diagnosed with the double cortex syndrome in the postnatal scan. We did counsel with expanding ventricles that it is possible there's an ongoing process due to a genetic or other cortical malformation, which will only be clear with a birthing scan. Some of the other, whenever there is an absent septum, the prosencephalon needs to be evaluated more clearly, and fetal MRI is very helpful with these conditions where cortical and other lobar, semi-lobar holoprosencephaly. So this is where there's partial fusion of the brain. This is with a big dorsal cyst. The top three are of one child, and then this is the sibling. So they both had identical malformations, which was on the spectrum of holoprosencephaly with partial fusion, a big dorsal cyst. They are both profoundly delayed, and we've done extensive genetic and whole exome testing, and the results have been inconclusive. Then this is another type of malformation where a cleft in the brain. This is a fetal MRI showing the cleft in the brain. This baby also had amniocentesis done, and this was thought to be due to insult from congenital CMV early in pregnancy. The evaluation of posterior fossa is also very challenging on the ultrasound, especially the way the baby's head is positioned and the view and the window of the back of the brain. And fetal MRI is very helpful with evaluation of the posterior fossa malformation. Now, the Dandy-Walker malformation, the new classification, it always is a spectrum. These scans are showing the most severe type. The other milder posterior fossa malformation could be a cisterna magna, where there is a space, but the vermis and cerebellum are normal formed, but the retrocerebellar space is expanded. Those kids can have a relatively normal outcome and no impact on their development. They can be mild inferior vermian hypoplasia only, and the rest of the brain is okay. Those kids also can have good neurodevelopmental outcome. But this is a scan showing the classic Dandy-Walker, elevation of the torcula, big retrocerebellar cyst leading to hydrocephalus, and the vermis and cerebellum are not formed. And both these siblings have chromosome 6p abnormality, which was associated with this brain malformation. Now, fetal MRI is also helpful in twin pregnancies. This was a baby where a twin pregnancy where there was bilateral strokes and bleeds on the MCA area and cystic expansion of the fluid space here you see, and this is the area of the parenchymal injury. We can also see other hemorrhagic lesions with complications related to twin pregnancies, and also anomalies due to vascular disturbance can be seen in twin pregnancy. So MRI again is a additional complementary test that can help with evaluation of the parenchyma of the brain. Now, fetal neurology and the counseling part, when a family meets, when they have a challenging diagnosis in the baby's brain, it's obviously a very stressful time. Similar to what also with neonatal neurology, when a baby is critically ill, surrounded by lines and tubes, and with family not having enough answers right away, what is the diagnosis, what caused this? So early in pregnancy, when they learn about these conditions, there's always these numerous questions about whether my child will be able to walk or talk, what will be their intelligence like, what are the visions the family had for their child, and how that is going to change. And then after the baby is born, further testing, genetic testing, waiting for tests, and each test has new questions associated. This helps, so the field of fetal neurology with early diagnosis helps us counsel and plan the pregnancy, the perinatal management, and the early postnatal management, and then the follow-up. What are the teams that are required? What is the follow-up and the supports, therapies, and genetic or other neuroimaging that may be required? And one important factor that remains in outcome for all these kids is the element of hope. So while there is this unknown and knowing like that how we follow the child over time will be the best guide, our goal is to give them the information, give them hope, and empower them so they are able to best support the child, because the role of a parental support and a stimulating developmental stimulation and supportive home environment is very important for the outcome for any child who's at risk for adverse neurodevelopmental outcome. So I will briefly present, we developed a fetal, looking at the challenges in the field, and this is a relatively newer field with any lack of guidelines or standardized approach. We conducted a survey through the Fetal Neurology Consortium that we developed late in 2020, and it's been an ongoing collaborative program for the last couple of years. And we sent out the Fetal Neurology Practice Survey to various centers in the US. These are some of the collaborators you see here on the map. These are the location of the institutes that responded. Not all might have responded, so it's possible other centers who were doing fetal consults did not respond. We had about 43 institutions, and look at the variability of the question. What is the earliest gestational age do you do the MRI? So starting from 16, 17, 18, 20, and then some with the late referrals. So there is a wide range in the practice. Typically, ultrasound will be done after the referral. Abnormal fetal MRI will be done after the referral from abnormal ultrasound. Now, what are the normal common consult diagnoses? So ventriculomegaly, absent septum remain the highest, agenesis of corpus callosum in the midline defects, posterior fossa malformations commonly seen, cortical, holoprosencephaly, and other spinal microcephaly. And then the increasing role of involvement of fetal neurologists and child neurologists in other conditions, a fetus with a cardiac anomaly, congenital diaphragmatic hernia. We know that these impact the brain and they can cause hemorrhages and hypoxic insults early on. And then the role of neurology involvement in fetuses who are at risk due to either twins or growth restriction and other systemic illness. Now, some of the centers involved genetic counselor with the combined, some separate, and some did not always involve. Trainee involvement was also not consistent. So there was a gap in the field education, as some studies have shown, where trainees may not be well prepared to counsel for prenatal diagnosis. Prenatal genetic testing was also very variable in practice. Some were counseling for it, some had the ability to do whole exome, and majority were doing postnatal testing. Postnatal follow-up was also a big range of how long are you following, when you routinely do postnatal MRI or not. Majority were doing it. Some were saying depending on the condition. Not all were using a standardized approach to postnatal follow-up for developmental testing. Majority would do a clinical assessment and developmental interview, asking them for various major milestones. But the ages and stages questionnaire was the second top method of evaluation. And then some were doing formal developmental testing. Now, there was big interest from the survey to develop clinical guidelines, educational modules, more information on fetal neuroimaging, fetal genetics, and practice improvement and the method of counseling, practical training for the field. Because the survey did show that there was so much variability in all the centers. So if you look at the field of fetal neurology now, over the years, when I started out my practice, we would be seeing maybe 1 or 2 patients a month. And now we have, in my center only, we may be having the few fetal neurologists we are there, we're seeing combined 5 to 6 or sometimes more on an average consults per week. So the field is really exploding, and there is increased demand for fetal consultations due to increased use of sophisticated neuroimaging, ultrasound leading to fetal MRI. However, the care is export-based. So what I'm doing at one center, the other fetal neurologist at other center is doing differently. And collaborations need to be established. So that's our primary goal with this consortium, to establish collaborations for developing guidelines, practice guidelines, and developing best practice modules and evidence-based care. Also, because of the newer fellowship programs, the collaborative curriculum development and training is also very important. And then having large-scale outcomes registry that can inform families with a more informed counseling of how the long-term may look like for a child. So all these are the important goals of the Fetal Neurology Consortium, which also led to the formation of the special interest group with the Child Neurology Society to expand the work and collaboration. Now, the Fetal Neonatal Neurology Program, it's a continuum of care, starting from pregnancy through early years of development of the baby. Now, the WHO group with the nationwide quality group on the lines of the Every Newborn Action Plan, Every Pregnant Woman, Every Child are very important initiatives. And the Fetal Neonatal Program curriculum aligns on those lines. What we can do to diagnose early and develop methods for better outcomes. Now, there are studies which look at birth size and brain function 75 years later. So this shows that with increasing the babies who were growth restricted or had exposure to adverse intrauterine environment had lifelong consequences for brain tissue volume and cognitive function. And the role of education and the environment, and those who had a higher education had more preservation of the brain volume. There are programs, if you look at this on the right, in Australian studies and some UK models, where they have said that direction of health expenditure to early pregnancy and perinatal and first 2 years of life, so the first 1,000 period, can really change the global burden of neurological disease across lifespan. Because if we are starting with early preventative care to improve the health, the reproductive health and maternal health, and the impact it has on the developing fetal brain, these can change the long-term outcomes and are very important for and align along the goals of any fetal neonatal neurology program. So that's all. These are some of the pictures. My school in Varanasi. This is IMS where I did my medical school and training and trained as an obstetrician. All India Institute of Medical Sciences here, where I was a high-risk OB, maternal fetal medicine. And then I trained my child neurology and fetal neonatal neurology at Baylor Texas Children's in Houston. And I'm currently here at Children's Hospital of Philadelphia. And that's all. Thank you again for this talk. I will stop sharing.
Thank you so much, Dr. Sonika, for that lucid presentation. In fact, it resonates quite a lot, I think, with the teams across India. Mm-hmm. And in fact, today morning on our clinical rounds, we were discussing a lot about ventriculomegaly. Now, we have a host of very eminent neurologists and leaders and opinion makers with us today who joined at short notice. And I will welcome them one by one and then request them to share their observations and their vision and how collaborations can further the cause of fetal and early pediatric and neonatal neurology in India. I am very privileged to welcome my mentor, Professor M.K.C. Nair. I think Professor M.K.C. Nair needs no introduction to anyone who's present here. Professor Nair, we've all been reading about Sir's work since the time we've taken up the pediatric courses. Sir has been the director of the Child Development Center, president of NNF, president of IAP, and the last major assignment which Sir has very successfully handled is the Vice Chancellor's position at the Kerala University of Health Sciences at Thrissur. So thank you so much, Professor Nair, sir, for joining. And over to you, sir, for your observations and for your inputs and guidances which you can provide from this forum.
Can you hear me?
Yeah, sir, absolutely. Loud and clear, sir.
Okay. So I have some sore throat. I am not able to speak well. I will put the whole thing in one sentence. Sonia has, it's beautiful presentation. Why it is beautiful? Because you are talking about the prenatal fetal MRI and the way you can diagnose, mix it with genetics to make early diagnosis. You emphasize on the first 1,000 days, very important. Okay. So one of the only problem is about the safety of MRI in the fetal. I would like you to make a comment on that. Otherwise, superb. We can diagnose so many things early. And now gone are the days when you talk about, low birth weight alone. Even though that is important, we need to talk about prenatal. Thank you, madam. Thank you. It was wonderful. Just one question is about the safety, repeated exposure.
Yes. So
whether ultrasound should be enough.
Right. So the ultrasound is the first line test. Fetal MRI is the next step complementary. Parenchymal injuries, posterior fossa, and detailed characterization of the brain can only be obtained by fetal MRI. When fetal MRI was approved in the 1980s, there was randomized trials done. Especially due to the concern for any exposure for the hearing, any injury or adverse effects. And those showed multiple trials were done, and American College of Radiology actually came up with a statement saying that fetal MRI is absolutely safe in pregnancy and should be used for diagnosis and prognostic counseling where abnormality is being detected. And CNS anomalies remain the top indication for fetal MRI. because of the limitations of the ultrasound. Mostly one MRI is done in pregnancy. We rarely or almost never do a repeat MRI. But sometimes when critical decision making can change, then we have opted for a couple. But in my last year, if I see, there was only like 2 or 3 patients who got a second MRI out of the 200-300 that we may have seen. So there's only one MRI, and it's been studied and shown to be safe in pregnancy.
If only one MRI, at what gestation would be the most productive, which will give you results?
So it's usually between the 20 to 22 weeks.
Okay.
Earlier MRI at 17, 18, 19, the posterior fossa, corpus callosum are still forming. So preferred is after completed 20 weeks of pregnancy. Obviously, when we are dealing with a very life-threatening or very complex brain malformation, where decision-making is involved, then the timing is also sensitive as to for decision-making in pregnancy, if there's any role of interruption.
Thank you. Thank you. Thank you, Vikram.
Thank you so much, sir. It's been, in fact, a pleasure having you here and taking inputs from you, sir. And now I move on to Dr. Naveen Jain. Dr. Naveen Jain, again, needs no introduction to this group. Dr. Naveen Jain has been trained with Professor M.K.C. Nair. And currently, Dr. Naveen Jain is editing the prestigious Cloherty's manual. And I'm sure all the DM students and the MD students who are here with us today, we've all grown up, you know, reading Cloherty and learning neonatology from Cloherty. So tremendous contribution, Naveen. And in fact, his unit at KIMS Trivandrum is one of the best units. And today morning, Naveen, I was discussing with the DM residents about your work, and what a surprise to have you on board here. So over to you, Naveen, and your observations on Dr. Sonika's presentation, and what sort of applications do you see of her work, and how the, you know, the new breed of neonatal neurologists, and we're getting so much of IVH in our units, HIEs, how we can, and malformations, how we should change our practices based on what Dr. Sonika has, you know, mentioned in her presentation. Over to you, Naveen.
Thank you, Vikram sir. And the only thing I can say about Madam's presentation is inspirational. One can only dream to have a journey from what Madam showed us to deep dive into learning of physiology of the brain of the growing fetus. We can see a lot of applications, ma'am. Like we see prenatal or what high risk obstetrics, the journey you took before you joined into this field gives us a lot of opportunity to prevent major morbidities when we pick up the scenarios which you showed us, like large fetal ventriculomegaly, a malformation of corpus callosum. But there are 2 other questions that I would ask you. One is, just like in fetal medicine, you would face same scenarios where we pick up a large number of findings which are not as grotesque or clearly abnormal, and there is no choice but to tell the family that I'm seeing something different. So we did our own audit, and we found that at least 9 to 1, we find out findings which are printed on the report, told to the family, but eventually translate into no outcomes of great concern. But it carries an emotional burden throughout repeated testing, genetics, and more imaging. How are we dealing with this? With, I'm sure that currently our understanding of this subject is limited to few experts like you, and therefore people would find findings and not know whether to report or not to report. So once I get to hear from you, then the second curiosity of mine that I would like to ask.
So you raise a very valid question, and that is the big part of this prenatal counseling, where the unknown, right? Even if we are able to diagnose clearly, the unknown of the long-term trajectory, which will only be clear as we follow the baby in the first few years of life. And each year teaches more. And then the diagnosis of some milder findings, even if we speak about the mildest finding and the possible slight increased risk of neurodevelopmental disorder, it adds to parental stress and very significant psychosocial stress and how it impacts. So that's where the role of this collaborative consortium and the special interest group in developing a more standardized approach to counseling, guidelines, registry, life course approach of following various conditions and seeing, oh yes, we have 500 babies with cisterna magna and they do well. Because the other day I had a family who read a paper that cisterna magna, there was a paper with like some 20-some patients, cisterna magna associated with some adverse neurodevelopmental autism spectrum. But that may be an associated finding, but the family got that information on Google. And so our role is very important for collaborative development of guidelines and prognostic counseling methods. But there's this whole field of psychosocial support. So the program that I'm leading at CHOP, where starting early with psychosocial supports, we actually have established psychologists, perinatal psychologists, who meet with the parents who are undergoing these prenatal diagnoses and endorse stress and would like to see a psychologist. So that's a whole newer field which needs a bigger approach to supporting the families, because giving them information is one thing, but supporting them through this journey is the big part of it.
Vikram sir, second question can be asked?
Yeah, please go ahead, Naveen.
Yeah, thank you. This fetal behavior has been elucidated for now about 30, 40 years or maybe longer by Dr. Brazelton, where he tried to look at how the baby fetus wakes up, moves, and responds. And this has been used largely in obstetrics itself by oversimplification in trying to understand the fetal brain health and timing of birth and so on. In neonatal neurology, we are aware that MRI changes, which is anatomy or photographic changes, and when you challenge it against neurobehavior assessments, sometimes neurobehavior assessments of seeing a baby looking around gives more information than looking into the fundus and looking into the MRI changes. So is one of you interested or already looking at fetal neurobehavior and correlating or adding on to the imaging findings and trying to say which corpus callosum you see is possibly just a variation and which one is probably very detrimental already?
Yes, so that's entirely being done as research right now. So looking the one picture that I showed with Sifredi et al., their study, and there are several others who may be looking at small cohorts of understanding the functional networks and connectivity. There are also studies with some of our collaborators in the consortium. They are looking at the sulcal patterns, the other gyral and sulcal patterns in association with ventriculomegaly or corpus callosum or other anomalies that may be more predictive of understanding and prognosticating the neurodevelopmental outcome. But these are all in the research phase.
And the last quick one, which of course I can always get back to Dr. Vikram, is that if our curiosity doesn't end, how do we connect and ask you more questions later?
I think, Naveen, we will be sharing the contact details later at the communities of practice, and I'm sure Dr. Sonika would be getting back to any unanswered queries at the end of this session.
Right.
So thank you so much, Naveen. I'll now have the privilege of inviting to share her observations a very young attendee, one of our undergraduate students, Khushbu Saha, who's had the illustrious honor of hosting and founding the Be the Change network of quality improvement, is cited on WHO headquarters Geneva webpage. So Khushbu has recently been appearing for matchings in US residency programs, and she had an opportunity to go and meet Dr. Sonika and look up at her work upfront. So Khushbu is currently working at the Institute of Human Behavior and Allied Sciences, New Delhi, and has got keen interest in pediatric and child neurology. So what do you, Khushbu, and what sort of applications do you feel this type of collaboration which you saw with Dr. Sonika's network in US can have a meaning for LMIC or low and middle income economies like India?
Thank you so much, Dr. Datta and Dr. Agarwal, for hosting this beautiful session. And I apologize for joining in late. I am currently on a 24-hour emergency duty, so you might hear some disturbances in the background. But I believe it was a very important step in having this collaboration done, because I feel like there are so many, like with my work, with my, I apologize for the interruption. But I believe that with the collaboration that we had with Dr. Sonika and the discussion that we have, the most important aspect which is translated out of her work is also the fact that we need to communicate with the patient. And something that I have observed working as a junior resident in the Department of Neurology is that the importance of patient communication and importance of counseling, that really matters, and matters even more when it comes to neurological diseases, because these are diseases which might not have a clear management idea, and they might have management treatment going on for years and years. And the psychosocial support that is provided as a part of a physician makes a huge difference in their treatment outcomes and in their overall outcomes. And I believe the collaboration that we have started with Dr. Agarwal can have huge impact in working as in the working of LMIC countries, because there are so many things that can be done from a telemedicine point of view, especially monitoring of treatment-resistant epilepsy cases. We have a lot of babies, we have a lot of patients here at IMPAS as well, around 1,000 to 1,200 patients every single day in the OPD, who come with treatment-resistant epilepsy cases, and they are being monitored with three drugs at once. So I believe like having a group of experts that who specialize in epilepsy medicine globally, we could collaborate on developing a network whereby we can solve the problems and we can solve the questions that we are trying to answer for the patients here in our country. Some ideas that we can work forward in future and build a collaboration. Thank you so much, Dr. Agarwal, for giving this presentation, for this beautiful presentation. Thank you, Dr. Datta, for hosting this presentation.
Thank you so much, Khushbu. I think the buzzword here is collaboration, counseling, and partnering with the community, and the role of telemedicine. So you got you straight, and thank you so much for joining despite a busy on-duty schedule here. And that shows your keen interest in improving the quality of care in whatever domains you are working currently. Now, ma'am, if you allow, I think for the next 5 minutes, you're already passing the 60-minute deadline. So we will just, if you allow, we have a set of questions from Dr. Amol Joshi. Dr. Amol Joshi is Associate Professor of Neonatology and one of the founding members of the Nationwide Quality of Care Network. I would request Dr. Amol Joshi to kindly unmute himself and ask these questions. So Komal, can you just unmute Dr. Amol and he can ask his questions?
Sure, sir.
Amol, over to you.
Thank you, sir. Good evening, madam. Good evening, all. Thank you for the excellent presentation. I'm working in a public hospital, and usually, hello, am I audible?
Yeah, you're audible, Amol. Please go ahead.
Yes. Usually, in a public hospital, we get referrals from obstetricians concerning any CNS malformation they detect in antenatal ultrasound, and they usually refer to us after 24 weeks for advice regarding termination of pregnancy. But then you might be aware, we have a PC-PNDT Act in India, which allows termination of pregnancy if the anomaly is fatal for the fetus or the neonate or in further life. So medico-legally, we are safe in advising that termination is not advised because this anomaly is not fatal. But then ethically, please comment on how should we go about in such cases. on not advising termination of pregnancy in cases where we know that this baby is likely to land up with lifelong morbidities?
Right. So the legislative part of it is a big issue of discussion. Lots of controversies in the US also in the recent year with the change in law and how it impacted practice, because we also have families crossing state borders to get the service they want just because of the restriction of the gestation for interruption of pregnancy. Now, I think it needs a larger scale advocacy and partnering of healthcare and the legislative bodies to see how we may take this approach. Because if there is a child with holoprosencephaly with supportive care, you may be having a feeding tube, seizure management, but they may live through all the challenges and grow into their teenage years, 20s and more, right? But if the counseling needs to bring in all the challenges that of adverse intellectual disability, intractable seizures, possible dependency for daily activities, so dependent for their care, and the functional aspects of the disability. So that needs to be brought into the conversation when we are very clear that the neuromalformation is associated with the adverse outcome that impacts global domains of development and quality of life. And I think the counseling from our side obviously needs to bring in all the adverse outcomes also, and if there is a positive or not. But then the going beyond the restriction of the gestation is more of a bigger discussion of how healthcare specialists can bring in this complex decision-making process, and not that it should be governed by a law. That's just another area of discussion and advocacy in itself.
Okay. Thank you so much. Can I ask one more question? Yes, actually the question is, we are all struggling to reduce cases of birth asphyxia in India, more so in public hospitals. I understand that there are many intranatal and maybe prenatal some factors which are beyond that control. But is it possible to predict by any ultrasound markers or any markers apart from high-risk pregnancies, babies who are likely to get asphyxiated? Is there any such study, or are you undergoing any such trial?
So there are some research trials looking at the metabolic measurements, but it's in early research phase. Doing like the spectroscopic and metabolic measurements in fetal MRIs to predict the time of injury, how it changes in babies fetuses who may be at risk for hypoxia, or growth restricted fetuses, or other complicated pregnancies. So, but it's all research trial. So the current field in fetal neonatal really depends on the obstetric measurements of the biophysical monitoring, the fetal heart tracings through labor, and what we are doing to intervene in the timely way. So very competent perinatal management with a team of specialists. That's the best approach. The imaging and other studies are all in the research phase where you could predict. But fetal neurology, the diagnosis that I discussed, many of those fetuses could be at risk for encephalopathy and adverse outcomes. In our study from Texas Children's, where we had a 10-year database, more than 40–50% of these kids ended up in the NICU. So having appropriate level of delivery to transfer to a center where you have the NICU support, and not having birth in the community and other smaller places where you could not support an infant who may need immediate intubation. And so the level of maternal care, the level of perinatal care, and place and location of delivery, all these can be planned appropriately based on the imaging and other challenges that we see that the baby may have.
Okay. Thank you, madam. Thank you. Thank you, Datta sir, for the opportunity. Thank you.
Thank you so much, Amol. Ma'am, we have two quick questions. I'll just read them out. There's a question from Janisha. Janisha wants to ask, what are the indications for a fetal MRI and what's the appropriate gestation? I think you already answered that with Professor MKC Nair asking you those questions. And then the last part of our question is, what conditions require fetal MRI screening? So should we, like, I think you covered that also, but just one line of clarification, whether they should go directly for fetal MRI or it should be a two-step approach after the ultrasound.
Okay, yeah, so it's always a two-step approach. Ultrasound is the first line for the level 2 scan or the anatomy scan, which is done at 18 to 20 weeks. If there is a suspicion of an anomaly, sometimes they even do a ultrasound with a tertiary care center where the ultrasonologist may have more experience in neuroanomalies, right? So, and what we call a neurosonographer. And if there is continued suspicion, then they get referred for fetal MRI. Fetal MRI is never the first step. It's a complementary test to the ultrasound.
So thank you so much, ma'am. I think that clarifies her Janisha's question. We have another quick question from Kirti Kundana. She says, for a child with antenatal ventriculomegaly, what is the best gestational age to do fetal MRI? I'm sure you've answered it. If I'm right, it is 22 weeks.
Yeah. Yeah, okay. Usually the fetal MRI happens anytime between 20 to 22, 24 weeks, depending on the referral and the scheduling and everything, but usually around the early 20s.
Thank you so much, ma'am. Ma'am, that brings me to two very important observations. As you're aware that this is a group of doctors and healthcare professionals, nurses and quality managers and frontline healthcare workers in India and South Asia working for improving the quality of care and reducing the no-do gap. Like you yourself mentioned, the survey which you have conducted across the United States of America, there is a large heterogeneity. And there is a significant variance in the compliance to the guidelines, and the guidelines often don't exist. And there's a tremendous no-do gap, I think, with many of the practices. I would just like to know from you that whether we want a similar, understanding of the background of the neonatal neurological practices across India. Do you see any hope for collaborating with the network over here in terms of improving the quality of care? And what amount of resources will be required if we move a step backward? I would say backward, not in the regressive manner, but backward in terms of the temporality in moving towards the early diagnosis at the fetal level. Like, for example, in most of our rounds, like even today morning, I was mentioning, we have a lot of IVH. In fact, we were discussing the IVH prevention strategies today morning only. So now, after your presentation, we realized that most of the IVHs are happening undiagnosed, and they are happening probably in the in utero period. And we are ascribing them to, some of the practices that are happening postnatally. And we not pick them up earlier. So in fact, the culpability and also the guilt factor and, everything comes on the obstetric and the neonatal teams that we're having a large number of IVFs. So what I want to know from you is that can we conduct a quality improvement collaboratives across India which looks at fetal neurology? And what sort of resources will be there, and what sort of collaborations can we have with the existing network which you are planning to launch in the US?
Right. So yes, so this is very exciting, and I think with this work of the consortium and the special interest group, I'm getting inquiries from outside experts who want to connect for this similar like guideline. What should we do? How can we collaborate? and improve outcomes in each center, right? So because this is a newer field and so heterogeneous, as you saw. So I think there is a big scope for collaboration. Now, the collaboration I would see is to start as a pilot with one center and try and see how we can change the diagnostic pathway, right? Start with a smaller cohort of what did the pregnancy ultrasound, but that'll be for someone who's had regular antenatal care, right? Was there something on that pregnancy ultrasound? And having a fetal MRI and then fetal neurology consultation. That could help you identify the timeline. Sometimes even ultrasound can identify the IVH if it happens, maybe if it didn't see at 20 weeks, maybe at 26 or 28 weeks when they are doing the growth scan. So I think a stepwise approach with a small pilot QI study with one center and see how we connect with others and develop a pathway to early diagnosis. Because yes, what we see in the neonatal period, a lot has happened in the pregnancy, but we are seeing when the baby is born and get the diagnosis of what we call HIE, hypoxic ischemic encephalopathy. But you do a scan and there is encephalomalacia or porencephaly, right? Look at one of the collagen mutations. One of the babies that I saw was actually referred as a HIE to our center. But when we did the MRI, the baby already had extensive injury. So that timing of injury and for diagnosis, for prognosis, and for better planning to avoid these adverse outcomes, what could we have done in the pregnancy and perinatal planning? So I think this is an important area to collaborate and develop. And like you said, you're being asked to counsel based on ultrasound, right? So why not add better information early on and add an MRI and the counseling process?
So I think, Amol, you got the answer to your question, and ma'am says very correctly. I think it's not very expensive, especially in the tertiary care centers, to have a fetal MRI. Ma'am, the most important part which we believe would be a challenge or a bottleneck, and you have good amount of experience in that, is the reporting accuracy.
Right.
You know, there would be tremendous heterogeneity. The machines are available. There would be a lot of colleagues who would be willing to do a fetal MRI. But that depends upon the experience and the reporting accuracy.
Right.
So that is something like even in Delhi, if we look at the centers, we would have only a handful of them who would have good amount of experience in reporting CNS in the fetus as early as 22 weeks. And I think with time, that is something which is going to come up. So resources are not going to be a major problem.
Right.
So with that, I think we will request Dr. Praveen Venkatgiri, Secretary NQOCN, for his concluding remarks. And any final words on take-home messages from Dr. Sonika? Over to you, Praveen.
Thank you so much for an excellent presentation and the interactions for the patients with which you answered and motivated youngsters as well as everyone. We wish to have more interactions with you as a group, and we'll bring to you more requests from our teams. Thank you so much, and thanks a lot for moderating session, Dr. Vikram Datta, and also thanks to our team who have made this possible for interactions, across the countries. Thank you so much.
And special thanks, Praveen, I would say, to our mentor and very senior colleague, Professor M.K.C. Nair, sir, for joining despite his extremely busy schedule, and very last moment invitation from me, I think at less than 24 hours notice, Sonika ma'am. So Professor Nair has joined, and especially Naveen and Khushbu. And we also had transiently, we had Ashok Kumar sir from Banaras Hindu University. So my special gratitude to sir as well, and our colleagues from Sanjay Gandhi Postgraduate Institute, colleges from Delhi, Banaras Hindu University, and all across the country and Northeast. So thank you so much, Dr. Sonika, and looking forward to connecting with you again and taking this initiative further. Really enlightened us.
Thank you so much for this invitation. It was lovely connecting with everyone back home, and I'm looking forward to some collaborations. I put my email in the chat if someone wants to reach out for the any questions, any collaborations, any educational sessions for their teams. Happy to do that, and we can connect you with others here who may be willing to do topics of interest for training and educating the teams. Thank you again.
Thank you so much, ma'am, and we look forward to teams joining the next communities of practice session and being a part of the Southeast Asia, and also the submissions to the BMJ 3rd edition South Asia Open Quality are still open. So I request the quality teams from across Southeast Asia to please submit their papers. All papers, first 15 of them would get a full APC waiver, courtesy UNICEF India. And so far, I'm sure you all are aware that nearly 40 plus original papers and studies have got published in BMJ from India at no cost to the authors, with mentoring from NQOCN. So this is a small contribution from the network to the quality revolution in the region. Look forward to more active participation. Thank you so much. Good night, and have a safe weekend, everybody. Looking forward to meeting you all again. Good night. Thank you,
Thank you so much,
Good night, and
everyone.
thank you so much. Yeah.